So we presented this morning at the AACR plenary the first results, the definitive results on the primary endpoint of the EORTC 1325 /Keynote 54 trial. And that is a trial where in the adjuvant setting, pembrolizumab is being compared to placebo in lymph node positive stage 3 melanoma patients after resection of their lymph nodes, their regional lymph nodes. The trial has an unusual design in the sense that it is set up to be able to address two questions, and not just the simple question, what is adjuvant pembrolizumab going to have in terms of impact on relapse-free or recurrence-free survival? So is the benefit going to be great, because anti-PD-1 is a very important drug in advanced melanoma, and so will we see fewer relapses, and will there be later relapses, these type of observations. And so we report on this primary endpoint where there is a very clear impact on relapse-free survival. There is a 43% overall reduction in the intention to treat population of relapses. So big difference. The second question in the trial is, I think, a very crucial and important question, which makes this trial so unique because it's never been done in an adjuvant trial. If you end up in the placebo arm in this trial, and you may get a relapse, or any patient who gets a relapse is actually unblinded at the time of relapse. If it turns out, if it's demonstrated that you were a placebo patient, you then have free access to 2 years of treatment with pembrolizumab for the relapse that you have incurred. And so it's a crossover trial design, which is extremely unusual in the adjuvant setting. Basically because you can compensate for what you may have won by the adjuvant use of pembrolizumab by giving an effective drug at the time of relapse for those who haven't had pembro. And then it may make up for everything, and then in the end, there may be not an overall survival benefit, overall survival difference. But yet, this is, of course, a fundamental question, because in the end, the question is, should we offer adjuvant therapy to the whole population, or should we just offer it to those who need it at the time of relapse? And so this question has not been answered by our report today, because it's too early for that. The overall survival data will reach maturity in about 2.5 years from now. So we will have to wait for it, but we finally have now a trial that addresses the most crucial question of all. Then there was a co-primary endpoint in this trial, namely the patient population who has PD-L1 positive tumors. Why? Because in advanced melanoma there is an indication that those patients with PD-L1 positive tumors do better on pembrolizumab treatment than PD-L1 negative tumors. There seems to be no indication in this trial that this is the case. It seems like all patients, regardless of substage, stage 3, regardless of PD-L1 expression, yes, no, and regardless of having a BRAF mutation, yes, no, the hazard ratios that we are observing in all these subgroups are very close to one another. And if you want to better understand what it means in absolute benefit, at 18 months, we have looked at where are the curves with the pembrolizumab treated patients and where with the observation patients. And roughly, we are very close to a 20% difference in absolute terms. We're very close to, in the intention to treat population, 72% of patients having a relapse-free survival at 18 months in the pembrolizumab arm, whereas it's roughly 52% in the placebo arm. So this is a very substantial benefit. And what we notice is that the curves are still diverging. So the pembrolizumab curve is much flatter than the descending curve of the placebo arm. And so this gives us great hope that it will translate in very significant distant metastasis-free survival differences, and it increases only the likelihood that it indeed will translate in overall survival benefit. But at least now by the crossover design, we are really testing that question. And because otherwise it would have already have been demonstrated, basically. So that's the importance of the clinical trial. Yeah. What makes anti-PD-1 such a great drug is its therapeutic index. So significant efficacy and relatively low toxicity. So with the immune checkpoint inhibitors, we are mostly looking at immune-related adverse events. And we know the frequency and the grade of immune-related adverse events, for instance, is a problem with ipilimumab. But for the anti-PD-1s, nivolumab or pembrolizumab, it's a completely different story. So we see much fewer immune-related adverse events and lower grades of immune-related adverse events. So they're easily manageable and they are easily resolved. So out of the 514 patients that were randomized into the pembrolizumab arm, there's only 39 patients who had a grade 3 or 4 immune-related adverse event. And so what everybody immediately asks is, how's the colitis? Because the colitis, grade 3, 4, is like 6, 7, 8% with ipilimumab. Here, it's 2%. So we only saw 10 patients with a grade 3, 4 colitis. Another question is always, how's the hypophysitis? So that it knocks out your pituitary gland. In ipilimumab, it's between 4 and 5%. Here, it is 0.6%. So we saw only 3 patients with a hypophysitis. And so what you do see as a frequent endocrinopathy that is immune-related, it's hypothyroidism as an end stage of a short hyperthyroidism and then sliding into a hypothyroidism situation. And we see that in 20% of patients. But this is just grade 1, 2. It's basically just lab values, differences, and if needed, if need be, it can be very easily treated with thyroxine. So overall, we have pretty much, relatively speaking, an ideal drug because of this therapeutic index. Yeah. Well, I think the great thing is that both nivolumab, because nivolumab was approved for this indication in December 2017, and pembro we expect to be approved in 2018. So we have a competition. Now, normally competition should drive down the costs because that's how it should be. So it's very important that we have alternatives like this. The original approval for nivolumab was for a more complex dosing, 3 milligrams per kilogram, and that means that you actually also waste material. And the strength, and it was given every 2 weeks. And the strength of the pembrolizumab schedule is it's every 3 weeks and it's a flat dose. So you don't lose anything, you just have a vial to give to the patient. But nivolumab was just only 2 weeks ago also approved for flat dosing every 2 or every 4 weeks. So that initial advantage is no longer there. And therefore I foresee that it will be a pricing decision also, among other things.